I'm honored and privileged to introduce another star in our department, Dr. Caitlin Griffin, who is one of the newest members of the Division of Thoracic Surgery, who joined us this past September of 2025. Dr. Caitlin Griffin earned her medical degree from Wake Forest University. She went on to complete her general surgery residency and fellowship at the University of Louisville. In Kentucky, one of the most premier general surgery and cardiothoracic programs in the country. She's board certified in general surgery through the American Board of Surgery, and also recently held her oral boards a few weeks ago. In addition, she has a medical science degree from Boston University. Dr. Griffin is deeply committed to surgical education. She serves as a core faculty under the direction of Dr. Patel, and she's also committed to community service. She makes meaningful contribution through her publications and active involvement in professional society, including the Society of Thoracic Surgeon, Thoracic Surgery Residents Association. Her passion for education and mentorship is reflected by her appointment, as I mentioned, as a core faculty here at us. And I'm absolutely thrilled with all the contributions that she's bringing in and continue to bring at the robust level, given her interests in esophageal, foregut, and thoracic surgery. Today, Dr. Griffin is going to talk to us about learning to walk on water, surgical swimming lesson. Dr. Griffin.
Is this working? All right, look at me. Good morning, everyone. Thank you, Dr. Alrafai, for that very generous introduction. So learning to walk on water, surgical swimming lessons, I'm sure everybody's wondering where I came up with that and where we're going. So I'm going to keep you in suspense for a little bit longer. Also, I wanted to welcome all of our applicants that are tuning in today. We're technical difficulties. Unfortunately, I have yet to acquire any financial disclosures. I am open to any and all contributions at this moment. Walking on water. So coming up with a grand rounds topic, I think is, especially for your first one, is challenging. The thing that I first thought about was, what is my audience? And that's also a really challenging thing because surgical grand rounds is a pretty spectrum audience here. We have people coming in, we have our medical students who, many of you are not going to be surgeons on purpose, probably. We have our applicants who are tuning in who very much hope to become surgeons someday. We have our residents who are in the process of becoming surgeons. We have our faculty, some are like myself at the beginning of their surgical careers, some who have been surgeons for decades. So having to come up with a topic that reaches everyone at all different levels of training. Then I also have to come up with something that I can talk about, something that I have, even in my early in career, have some kind of mastery of, which sounds ridiculous to say in month 4 of facultyhood. Then I also have to take into account the residents are probably up to their eyeballs in ABSITE studying and neoadjuvant lung cancer therapy or new immunotherapy for esophageal cancer is probably not going to hit real hard at this point in January. So what I do know is surgical training. I just finished 7 years of it. And thinking back as a resident, one of the things that always struck me was looking at my attendings, my chiefs, they always knew what to do. When I was in the ICU and we had a sick patient, if we were in the trauma bay and it was crazy and hectic and there was blood and crashing patients, we were in the operating room and it was terrible anatomy and complicated and just hard. They always knew what to say, what to do. They always had the answers. They always looked like they walked on water. I always thought that they were infallible. They were perfect. And I just didn't think I was ever going to get there. How was I ever going to? I struggled to write a consult note. I couldn't figure out how to replace potassium. How was I ever going to get to be that good? I was never going to get there. And one of the things that I realized as I progressed through my training is you're never really perfect. You are really just figuring it out as you go along. And it's really just the sum of your experiences. And in fact, you're not really walking on water. You've just had enough experience that you've learned where the stones are. And so as I progressed through training and I became a chief and then a fellow and finally an attending, you've amassed these different experiences through working with different coworkers, attendings, fellows, and honestly patients who are often our biggest teachers. These different experiences, and that cumulatively make us into the surgeons and the practitioners and really the people that we are. And so I know what I want to talk about, but how am I going to impart that? So I've got the what, but what am I going to do? How's the how? One of the quotes that I had heard as a medical student that I always really liked, a little morbid, is René Lariche, who was a French physician at the turn of the 20th century. And the quote is, "Every surgeon carries within himself a small cemetery where from time to time he goes to pray, a place of bitterness and regret, where he must look for an explanation for his failures." And so this is, I like to think of myself as I identify as a bit of a Wednesday Addams. This is a little dark even for me. I don't think of myself as carrying a cemetery. I think of mine as a bookshelf. I have a series of patients and experiences that I will visit on a bookshelf from time to time. And they're things that I refer to and visit when I have a similar experience, when I want to share that with a fellow trainee, a junior resident, a medical student, when there's a particular situation. And it's something that I go back to reflect with. And I think I am willing to bet that any of my fellow faculty members, you all have patients that you remember over the course of your careers and training, and you probably remember some names from either great cases or bad ones that you hold with you and that taught you something, for good or for bad. Pete Blabber, this book was is a former Delta operator. This book was recommended by Alex Eastman as a trauma surgeon who, I'm not sure if he's still at UT Southwest. I did a trauma rotation as a fourth year medical student and worked with him my fourth year. And he's actually he's a trauma surgeon that is embedded in the Delta SWAT team. And I was listening to a podcast that he was interviewed on, and he recommended this book. It's a really interesting book. It's a book about leadership, and it's written from the perspective of being someone who commands a Delta Force team. And the parallels between the military and medicine are fantastic, actually. The premise of the book is that the 3 M's are the mission, the men, and me, and that organizing your philosophy for leadership is that you have to first take care of the mission, patient care. The mission has to happen regardless of any other factors. The second thing you have to take care of, and you have to ensure the safety and the success of your men, your team. And then finally, it's me. It's yourself as the leader. You're the last one in. You're the last one to eat. You're the last one home. You're the last one on the helicopter. And so it's a really interesting book. There's a lot of parallels. And leading a team of special forces guys, these are all type A alphas. I really don't love that term, but and leaders in their own right. And surgeons specifically are also very similar to that. We are all people who like to be in charge. We like to call the shots. And any one of these, special forces guys, you could take any of them on a team and drop them into a boardroom, to a professional sports team, a university, a hospital, and they're naturally going to assume a leadership role. How do you lead a group of those people and not just have a group of chiefs trying to go in a bunch of different directions? And the way that he describes this and how he imparts this information is through anecdotes. And he does this using sort of like a Aesop's fable method, where he has sort of a title that'll be sort of, that's the lesson. And then he uses a story to illustrate. So an example would be, he says, always trust the man on the ground is the lesson. And the story is something along the lines of, they have some objective they have to achieve, and they have conflicting information. He has intel from the drone and satellite footage from the Air Force, and then he has information that he has from shepherds that live in the valley in Pakistan where they're trying to do these maneuvers. And they're conflicting information, and he has to make a decision who's he going to listen to. And he goes in the story, he goes with the intelligence from the satellite information from the Air Force, and he's wrong. The guys that the shepherds were correct. The guy always trusts the man on the ground, which also, I picked that example because it also mimics medicine quite well. The men on the ground are nurses. And so it's a really interesting book, but the way that he tells the way that he imparts his information is it's anecdotal, and it's a powerful method, I think, because as humans we like storytelling. Storytelling is a super old art form. I think as soon as humans were gathering around fire pits and we were telling stories, and it's an easier way to impart information, and I think we hold on to it. I'm gonna see if this will work. And so Brene Brown is an author and a researcher. I don't know if anybody she's been mentioned previously in a Grand Round. I think her TED Talk should be, it's on Netflix. It should be mandatory viewing for anyone, but certainly somebody in medicine. She is this sounds sort of as a downer, she is a shame researcher. But I'm gonna have to switch over to YouTube real fast. Nope, not that. This, yes. Hopefully the volume will work. And so this is part of this. She gives this speech in her TED Talk. This is not her TED Talk, but this is sort of the section of the speech of her talk. And it's talking about being in the arena and being essentially being vulnerable and sharing experiences, but also being authentic and putting yourself out there. Oh, be careful. And Okay. So at this point, I had what I wanted to talk about. I wanted to talk about the experiences and training and the lessons that we learned that make us so that it looks like we're able to walk on water, but it's really the things that we accumulate, the experiences that we've gotten that teach us where the stones are. And through the vulnerability that Brene Brown teaches me to have and the storytelling methodology that I got from Pete Blabber and the content of my bookshelf that Renee Lariche talks about, I had the method that I wanted to use for my talk today. And so let's get into the swimming lessons, the surgical swimming lessons. So the first is going to be, the first cut is the deepest. When I was an intern, it was November of my intern year, I was on the transplant surgical service. And one of the cases, it was sort of an odd extra service that we covered was gastric stimulator battery changes. It was as the intern, it was a nice case because you got to do some sewing and you got to close a lot of incisions. And so I had your responsibility was, it was a private surgeon. Your responsibility was you came in, you got to do the case, and they were outpatient procedures. So we had a patient come in. She's a morbidly obese woman, Ms. Belgium. All of my names and things and details have been changed, obviously, to maintain HIPAA. Ms. Belgium came in, the case went normal. We changed out her battery. If you haven't seen one, they're about the size of a pacemaker, essentially. You make a small incision on the abdomen, and the pacemaker is tacked with ethibonds onto the fascia so that it doesn't flip in the pocket. Case goes fine. She goes home, and I go about my day. I come into the hospital probably 3 days later, and one of my co-residents tells me, "Hey, did you see that Miss Belgium got admitted overnight?" And I was like, "For what?" She's like, "Well, she came in with necrotizing fasciitis." And I said, "What?" And she's like, "Her abdominal wall." And I was like, "That doesn't really?" And they said, "Yeah, she came in, she tried to call the Dr. Hughes and he wasn't answering. And so she came to the emergency room because she said that she had poop coming out of her incision." And I said, "That doesn't really make a lot of sense." And I said, "Well, okay, so like what happened?" And they said, "Well, she had to go to the operating room. The general surgery team had to come in because they couldn't get a hold of your attending. She had to go to the operating room last night." And I said, "She okay?" They're like, "Well, she's on a lot of pressors. She's in the ICU. She's still intubated." I said, "Oh, okay." And it's still early on in intern year, and a lot of that doesn't really make a whole lot of sense still to me. And so what I then find out, having talked to my chief, what had happened was what we had thought was her fascia was actually a hernia sac. And what I had put ethibonds to was her small bowel in her hernia sac. And so when you for the medical students, when you put stitches into small bowel, that is not good. She had lost probably about half of her abdominal wall through neck fasc. And I walked into her hospital room and they were doing her dressing change. And it took 8 Curlexes and 15 ABDs to dress that wound. then I can still remember standing in that doorway and watching just Curlex after Curlex come out of that wound and standing there and saying to myself, I'm not doing this. I'm going to go be a dermatologist. I am not. Nope. I was like, I'm not going to do this. You hurt people when you do this. This is bad business. I'm not. And at the time, I felt like I had killed this woman. And now, as my chief and various other attendings had pulled me aside at multiple intervals during this lady's care. She required multiple operations. She developed an EC fistula, all of the complications that you would assume happened with this woman. And I'd been pulled aside multiple times. This is not your fault. An intern is not expected to have this level of responsibility. And now, as an attending, even as a new attending, if I took any of our interns to the operating room and this happened, that is 100% on me. And I know that that is my responsibility. It's not the intern's responsibility. But for the first time, and pretty early on, I had my first occupant of my bookshelf. You will develop very close friends in residency. There are several of my friends from residency. If I picked up my phone right now and I called them and I said, do you remember Miss insert real name? They know exactly who it is and they can tell you exactly this story because they know, partially because they were there, but also because we've talked about this ad nauseum. The point being is that the first time, and you will all, whether you are a surgeon or not, you will have a patient that, whether directly, if it is your fault or not, will have a bad outcome because of your action or inaction. And you have to sit with that. It is really hard. It was very hard at the time. It still is hard. Her life was absolutely shortened because of the 2 stitches that I put in her hernia set. It's funny because it's often mistaken, I think, that surgeons are cold and that we just don't have any feelings. I work out at one of the Muay Thai gyms in town, and my trainer had said to me, we were talking about me being on call and I had to operate on somebody or whatever, and he was like, you must just like have no feelings. You just like turn it off, right? I said, no, it's different. You compartmentalize it because you can't be thinking when you're operating on somebody like, oh, this is Jenny and she has 3 children and her husband is Harold and they've been married for 45 years. But if you don't appreciate the fact that this is a person with people, then you need to get out of the game. If it stops affecting you, you shouldn't be doing it. But at the same time, it can't paralyze you. But if you don't stand in the room while miles of Curlex are pulled out of a wound that you caused and you don't feel a type of way about it, then you need to get out of the game. Over the course of your career, you will have multiple Miss Belgiums, and they will happen at different levels. Miss Belgium was my first bad outcome complication. She was probably the complication that I was the least culpable in, I would say. But there were others. I had my first esophagectomy, I did skin to skin in fellowship that had a leak. That has a different level of responsibility. I had my first, as an attending, my first post-operative patient had a real complication earlier this week. I had a patient code overnight. That one really is my responsibility. I'm the operating surgeon. It doesn't get easier, you get better at handling it, but learning how to handle and deal with and communicate and process these experiences when they happen, because they are going to happen when they start early, and acknowledge that it's normal to happen, is an important part of growing up, because you will all have Miss Belgiums. You will have many Miss Belgiums. Some lessons have to sting to stick. So this is a case from fellowship. This is my 2nd year of fellowship. This x-ray is going to be, maybe it's not too hard to see, but so this is an x-ray that has an airway stent in it. And so if your trachea here, the airway stent is outlined here. And here's your groin-up. Right here. So here's your left main and your right main. So Agnes was a woman in her 60s who had known or was believed to have papillary thyroid cancer and was scheduled for a thyroidectomy with ENT. We were on standby for, it looked like it extended below her sternum for a possible, helping them out with a partial sternotomy. Unfortunately, she presented early to the hospital in respiratory distress from tracheal compression from her tracheal mass, or from her thyroid mass, excuse me. And we took her to the operating room with ENT. She had been admitted for a few days ahead of time for scheduling reasons. The ENT wasn't ready to take her to the operating room. There's a lot of back and forth, a lot of political things. It took her a while. She was in the hospital for about a week, actually, before we could take her to the operating room. We get in, we scope her, we do a bronchoscopy, and the tumor's eroded through her trachea, which papillary thyroid cancer does not really do. Take biopsies, and it's actually anaplastic thyroid cancer, which is a bad actor. And of course, this lady is Mary Poppins incarnate. I'm not a superstitious person, but if you have a really bad cancer, chances are you are a really nice person. And so she obviously has no surgical options, but needs to get a port and get set up for chemoradiation. So she's still in the hospital for a couple of days, and we get called because she's still having some shortness of breath. And so the decision is made to put an airway stent in her. We put the airway stent in. She's doing fine. She's getting ready to go home. And this was her x-ray on the morning of discharge. And if you can see, the stent looks like it's over her left main bronchus. So I go to my attending and I was like, I think this stent moved. Airway stents are not really like esophageal stents. Esophageal stents pretty much stay where you put them for the most part. But airway stents are kind of a pain. They shift all the time. They're not especially when you're coughing, they move. And it looked like it had shifted to me. I said, I think she's jailed her left main. He's like, I don't think so. It's probably just an angle. He's like, how's she doing? I was like, she's fine. She's like chatting well. She's comfortable. He's like, she's fine. She can go home. I was like, I really think that this is not in the right spot. And he's like, we got a 2-view x-ray. I thought it'll make you feel better. We had a 2-view x-ray. It's like, it still looks like it's jailing the left main. And he's like, I think it's just the x-ray. I think it's just the angle. Like, what does she look like? I was like, she looks fine. And he's like, I think she can go. Like, all right. So I called ENT and I was like, she's not admitted to us, she's admitted to ENT. And I was like, all right, she can go. She's looking good. And so as a CT fellow, the time that I left the hospital before 6 p.m., I can count on one hand missing 2 fingers probably. And this was one of those days. And I was headed out, I was walking out to my car and it was probably 5:30. And my hand is like reaching for my car door and my phone rings. And it is the on-call in-house resident. And he says, hey, I just got a call from ENT that some lady that you guys put a stent in is like having respiratory distress upstairs. And they want to know if you're still here. And I was like, yeah, I'm still here. I was like, I'll be right up there. So I walk up and she does not look great. She's like standing okay, but she's audibly like stridorous. It's like, okay. And the ENT chief, Duffy, that is his real name, is there. And it is April. It's April, and ENT changes over. Their chiefs start to fade to black in April. I know, aren't you guys jealous that they fade out real early in that time? So so he was a 3 rising to a 4. So he was in a new chief role at this point. Duffy's a good kid. He'd been my intern a couple of times. And so they're like, we're gonna do a DL to check on her. And I was like, no, you're not. We're not doing that up here. We're gonna go to the operating room. We're gonna intubate her, check her. It's her stent. Her stent's in the wrong place. We're gonna go to the operating room. I was like, keep an eye on her. I gotta go set up the operating room. So I go call the attending. I was like, we're taking this lady to the operating room. Her stent's in the wrong place. Are you still here? And he's like, yeah. He's like, all right, well, you were right. He's like, I know. So that worked. So I'm waiting in the operating room and I'm actually going and getting all the stuff. And I hear from the front desk that Charles, who's our patient transporter, because it's all after hours at this point, there's nobody around. And that he's calling for anesthesia to come up to get the patient. He's like, she doesn't look good. She looks really bad. And anesthesia goes up, gets the patient, brings her down, and she is gray. They're bagging her and they bring her into the OR. She's standing like in the 40s. They get her intubated. She comes really close to coding. We change her stent. It was jailing her left main. We change her stent and she's fine. As soon as she gets intubated, her stats come up. She gets extubated after the procedure. It's fine. I talked to anesthesia. She's like, and they said, yeah, no one was in the room when we went to go get this patient. I said, come again? She was like, yeah, she was alone. No nurse, no. And I said, ENT wasn't there? And she's like, they're like, no, there was nobody with this patient. It's like, it's pretty clear that I had told the ENT chief, and he had 3 minions with him, that somebody needed to stay with that patient. They were like, yeah, nobody was in the room. It's like, interesting. So we'd finished the case, and I pick up my phone and I go to call Duffy. And I have a choice, because at this point I'm mad. I'm real mad. And I'm mad for a lot of reasons. I'm mad because I had to think about it, because I'm mad. Duffy is a convenient target at this point. I'm mad because this lady had a delay in diagnosis because the ENT couldn't be bothered to change the schedule to fit her into the OR. So we kicked her down the road for a week. I'm mad because this lady's path had really looked like anaplastic. It didn't look like papillary when I went back and looked at it. I was mad because I had said 3 times earlier that day that the stent was not in the right place and I hadn't been listened to. And none of that really had anything to do with Duffy. And when I really got down to it, what I really was scared, is I was scared that that lady was going to die upstairs. And part of that was Duffy's fault, but me being scared was not Duffy's fault. And so I had a choice. I could call and scream at Duffy. And where I trained, getting somebody on the phone and reaming them was not uncommon. That would not have been, I would not have gotten flack for that. And so I called him and he picks up the phone. He's like, oh, hey, how'd it go? And I was like, yeah, it was slipped. We changed it. Like, she's doing okay. We're going to extubate her. She'll go back to her floor. She looks fine. And he was like, yeah, thanks for doing that. And I said, Duffy, she came really close to coding. He's like, what do you mean? And I said, there was no one in the room when Charles went to go get her. And he was like, oh. He's like, I messed up. And I said, yeah. I said, but when you have an unstable patient like that, you gotta leave someone with them. And he said, I didn't think about it. I had to, because sort of as an aside, in general, we cover 3 hospitals at a time. Nobody does hospital-based services kind of like we do here. You cover 3 hospitals every service. And so he needed to make sure that he was covering a case and getting everybody to check out and making all of his attendings happy. And he's a new chief and he's many masters to keep happy. And I said, some lessons have to sting the stick, Duffy. You will not forget this and you won't make this mistake again. Some things have to really scare you so that you don't make that mistake again. And so the lesson for me was also sometimes showing grace and giving someone the benefit of the doubt and letting them make the mistake and not berating them puts them in the space where they're able to learn from it without being put into a headspace of being shamed or ridiculed. And they're actually able to learn from it and not just shut down and get defensive. Unfortunately, this happened again, and she went home, she slipped her stent again, and we ended up having to replace the stent a second time. And then she went on to get her chemotherapy. Unfortunately, anaplastic thyroid cancer does not have great outcomes. All have eyes. When I was a 3rd-year resident, I was on the surgical oncology service, which is a very busy service, University of Louisville. It's largely based at our biggest hospital, which is called Norton. And I was towards the end of my third year. And the best part of end of your third year is you are coming to the end of in-house call, which is awesome. And I was actually on one of my last in-house calls at Norton, which is a 600 bed hospital. You're the only surgeon in-house. It's awful. It is a terrible call. I was on call and I got the requisite 2 a.m. pancreatic mass consult, which is so fun. So I go to see this patient and I'm, in the headspace of I'm almost done with in-house call. Light is at the end of the tunnel. I'm going to go see this patient and hopefully I can knock out this note, see this person, sneak in, sneak out, maybe get a 30-minute nap before I have to go see the 9 million surgical oncology patients that I have to go see all over this hospital, and then round, do cases, and then go home. So I sneak into this room, hoping to not turn on any lights, not really wake up anybody, do the legally required physical exam maneuvers so I can check this person, get my note done, get the heck out of there, and maybe get a nap in. So sneak in and start to kind of whisper talk to the patient. And there's a woman sleeping in one of the chairs, and she wakes up and she's like, oh, and I was like, oh, hi. I'm Dr. Griffin, just coming to check. I'm one of the surgery doctors they asked us to come to see you because of the spot on your pancreas. And she goes, Dr. Griffin? And I said, yes, I'm Dr. Griffin. And she's like, Dr. Griffin? And I was like, anybody in the room currently with 2 X chromosomes knows what I'm about to say next is I'm ready to be like, yes, I am the doctor. No, I'm not the nurse. And she's like, so she gets up and I was like, no, I don't want to have this long conversation. I just want to do this quickly. She gets up and she goes to turn on a light. And she looks at me and she goes, I know you. And I was like, oh, this can't be good. And I'm looking at her and she's looking at me and her husband is just in the bed and he's just kind of looking back and forth at us. And she's looking at me and she goes, you took care of our son in the ICU last year. And it takes me a second. And then I go, yes, I did. I said, he was in a car accident. And she's like, yes. And so it took me a second, and it was he was a 20-something-year-old kid who'd been in a pretty bad NBC. He'd been driving home from work. I don't totally remember all of the extent of his injuries. I do remember that he had to have his jaw wired with OMFS, and I got in a lot of trouble for not having secured his enteral access prior to letting OMFS take him to the operating room. But there was a question as to whether or not he'd been drinking when the car accident had happened. And somehow when he'd come through the trauma bay, he'd just come through the trauma bay and then he was an ICU player. So he went straight up to the unit. And he hadn't had his alcohol level drawn. He'd had a tox screen, but they hadn't drawn alcohol level. And his parents were beside themselves because they were just, the police are saying that he was drunk. The police are saying that he was drunk. And I had just been going through the labs and filling in holes. And so had ordered a blood alcohol, which was negative. And it just sort of sat with the family. It was it really wasn't at all an extraordinary, he was just another kid that had been in an accident. And the only thing I remembered was the thing I remembered was I almost never in the ICU ordered a blood alcohol. And I got in trouble for not having discussed a PEG or any kind of long-term nasogastric kind of feeding access prior to them wiring his jaw shut. But I had sat and talked to them because they were so worked up about him, worrying about him being charged with drunk driving. And I was like, oh no, his blood alcohol level is 0. He's fine. And so coming back to the room at Norton when now the husband is admitted with a pancreatic mass, this family has the worst luck ever. And she was like, no, I remember you. You took care of our son and you sat with us. And they're giving me all of these details that I was internally very embarrassed that I did not remember at all. And then she starts to tell me, I was like, oh, well, how did your son do? And she's like, he went to rehab. He's home now. He's back at work. He just got engaged. And these are all details we never get as residents. especially because we rotate, we change rotations every month. And you very rarely, you're never back on service when they come through clinic again. Like you don't ever hear any of these things. And I was like, this is, thank you so much for telling me all this. We never get to hear any of these things. And it was actually very funny. So then we rounded the next morning and they were like, it was just so great to see you. Like, we're so happy that you're on the team. And the PGY3 on a surgical oncology service is like the lowest on the totem pole. I can't even begin to tell you. And so we go to round the next morning. And so Dr. Egger is the attending, Mike Egger, I don't know if you know him, is the attending, and the fellow is there, as well as the PGY5 for me and then an intern. And we're rounding on this patient the next morning. I'm very much at the back of the crowd. And the wife is looking to see if I'm there as Dr. Egger is trying to talk to this patient. And I'm like, I'm here. Egger is like, what? I was like, I took care of their son. And then she's like, what does Dr. Griffin think? And I was like, Dr. Griffin doesn't think anything about what they do. You should listen to Dr. Egger. I don't have anything to do with this. And I was like, I concur very much so, I promise. But the thing that I think that we should all keep in mind is that we will have thousands of patients over the course of our careers. And even the unluckiest of patients will really only have a handful of surgeons in their lifetimes. And the details and the patients will become a blur for us, but they will remember us in great detail. They remember the things that we say, the small things that we do. And I've gotten notes from patients that say things I'm like, I can't believe that you remember that I did that, said that, whatever. And everyone is watching. Furthermore, as a trainee, it's easy to feel, especially as a junior resident, that you are superfluous, that you're not like contributing, or that like you're not the chief doing the case. You're not the attending running the clinic, ICU, whatever. But people are still watching, and there's not a lot of us as surgical residents, surgical fellows, whatever. People know who you are, and it's very easy to have a reputation, good and bad, very quickly. Especially and that's the case too, when you transition, when you leave residency and you go to a new place for fellowship. I stayed in the same place for all of my training, which was a good thing, I think, because I was really able to build deep and lasting relationships with people. But the nurses all know who you are. And it's very hard to hide behind a collective, the patients are the patients, the nurses are usually the nurses. The surgery residents are, you're Jim Bob and Bobby Sue. They know your names and they know who you are. And so everyone is watching for good and for bad. And I think we should always strive to act like it's all being recorded. It's all going down in patients' memories. It's going down in the history of how we want to be remembered. But I think that it's easy to forget that something that is a small part of our day is a huge part of our patients' lives. I will frequently tell the residents and the medical students, especially a lot of what I do is I operate on people with cancer. It is a normal Tuesday for me when I talk to patients in clinic who have esophageal cancer or lung cancer. It is a before and after event in most of these people's lives. And it's a lot about this is perspective and maintaining that and understanding where you fall in the spectrum of hospital, patients' lives, and the patient experience. No task is too small to humble you. Hiram Polk is a bit of a legend, I think, in the general surgery community. Hiram Polk. But he's probably got to be in his late 80s now. But says all sorts of unhinged things, but does have some pearls of wisdom every once in a while. And I made a Polk bingo as a resident for M&M for the random things that he would say. And one of them is that there is no task that is not small enough that it can't humble you. So this is a story from probably the very end of my first year in fellowship. So this is coming at the end of 6 months on the adult cardiac service. This patient had a mitral valve replacement. I did not do his surgery. I was in another case at the time. When you close, his case was uneventful. When you close sternotomies, especially if you're doing a valve case, you don't have to get into the pleura, so the pleura are often intact. But when you close the sternum with wires, it's not uncommon to catch the pleura. And if you just catch the pleura, you'll have a little bit of a pneumo, not a big deal. It'll often go away on its own. But if you nick the lung, you can get a pneumo and an air leak, and you will eventually sometimes have to put a tube in. So this patient had come out of the OR with a small right-sided pneumo. And they'd watched it for a couple of days. I had been in the ICU and talked to the attending. They'd sort of sidebarred me and been like, hey, you might have to put a tube in this guy, just like so you know. It's like, all right, it's fine. We are very fortunate here in that IR is very cooperative, and they put in a lot of tubes and do a lot of thoras. I was IR where I did fellowship. I probably put 3 or 4 pigtails in a day after I was done with my cases. And so, and our ICU was run by anesthesia intensivists, and they did not do chest tubes. So they had sort of given me a heads up, and it was kind of getting a little bit bigger. And I talked to Dr. Gansel, who's the attending, and I said, hey, do you just want to go ahead and put a tube in this? Or he's like, no, let's wait. I said, okay. And so another day or two goes by, and I get a call from the intensivist at like 3:30 one morning, and she's like, hey, he's really going up in his oxygen requirements. I think we're gonna need a tube. And I said, all right, no problem. I'll just come in for the day. So I like get up and I come in. I go in, I talk to him. He's like on probably 15 liters, and he's like jovial and chit chat and whatever. And I go in, and I put a tube in, and we're chatting the whole time. It's fine. And talk to him, and I look at the X-ray, and I look at it, and it's like the picture looks a little weird. This X-ray is sort of hard to see. Pigtails somewhere in here. Like it didn't really unfurl very well. And I was like, and meanwhile, I have like a bunch of stuff I gotta go do. And I'm just like, all right, it looks, I was like, it just looks weird. I was like, I bet it's just stuck onto the pericardium. Pneumo's gone. He feels better. And I was like, okay, I'll get up to suction. I got a bunch of air out. And I was like, okay, sounds good. Moving on. So I go about my day. A couple of days later, the pneumo's better. He's ready to move down out of the unit, and they go to pull the chest tube. And one of the other attendings gives me a call and says, hey, they pulled the chest tube on Mr. Jones. And I was like, Mr. Jones, he's not one of mine. And they're like, oh, you put a tube in him for Gansel a couple of days ago. And I was like, oh, right, yeah, that guy. And when they pulled the tube, they noticed there was a wire sticking out of the chest. And I said, what? And I was like, they were like, yeah. So they had called, this was a different cardiac attending. She happened to be in the unit. And they called her over, and she's like, yeah, I just got like a pair of like a hemostat and grabbed it and pulled it out. And I checked it against like a fresh wire from a kit, and it's intact. It's the whole wire, but it looks like the wire stayed in the tube when you put the tube in. If you look, there's the tube. And here's the wire. Now, most post-op cardiac patients are not lacking in wires and tubes and monitoring. I was horrified. I have put in probably not 1,000 of these. I have put in hundreds of these tubes. And I immediately went and talked to the patient. Was fine. The wire come out. He had no pneumo. There's no like that adverse effect to the patient. I was horrified. This is like a never happened thing. I went and I talked to my attending. I apologized profusely. I said, I have put so many of these in. I cannot imagine how I let this happen. When I pull out, so you put these tubes in over a wire, obviously, and there's a stiffener in the tube, and you remove the wire ideally and the stiffener. And I have always done both at the same time, pull the wire and the stiffener at the same time. And the wire must have been left in, and I must have just pulled the stiffener out. And so this gets escalated. I have a meeting. We have a formal quality improvement review, and meet with risk management, the CNO, my attending, the chair, hospital lawyers, the radiology department, It's a full like risk management review board. I mean, it was a true Swiss cheese example of an error. None of the chest x-rays were ever read with anything about a wire. Multiple attendings, surgeon and intensivist, had looked at these x-rays with the wire visible. Nobody had caught it. And in the meeting, we talked about, so my chairman chalked it up to and was like, oh, she's tired. This was done at 3 a.m. She's a CT fellow. She's tired. And I mean, I didn't there are a few things more fatal than publicly contradicting your cardiac surgery chairman in public than that. But I wasn't tired. I was complacent. I put hundreds of these tubes in, and I was like, I don't know, like, how many of these have I done? You're on autopilot when you do something like this. And they asked when we had this meeting, what I was going to do differently. And what I said, and what I have been doing since then for every one of these that I have done, is I said, well, for one, I take the wire and the stiffener out separately now. And I stare at the wire just like you maybe do when you turn off your curling iron or your oven before you leave the house and you're like, I pulled out the wire and I put it to the side. I said, but furthermore, when I teach junior residents how to put in pigtail catheters, we have a conversation and I tell this story. Not in front of the patient. I wait till after we have put the tube in and then we have this conversation outside of the room. I said, but every single time I put one, I mean, as a fellow, you very rarely, at 3 a.m., yes, I put these tubes in by myself. But as a fellow, I'm almost never putting these tubes in alone. I'm doing this with a junior resident. And every single time I have done that since, we have this conversation and I tell this story as to why I take them out separately and the fact that this can happen. And I see in real time, and often an intern, and they watch as someone who they think walks on water shows them that really I am standing on stones. And previously, I got dunked really hard very recently. Whatever you do, don't stop pedaling. So this is my last one. Okay, we're doing pretty decent on time. So when I was 4, my dad, I'm a military brat. My dad was career Army, and when I was 4, my dad was deployed in Desert Storm. And I decided, my mom had also just had my younger sister. And I decided that was the perfect time to learn how to ride a big girl bike. I was done with training wheels. I wanted to learn a big girl bike. My mom was probably 6 weeks postpartum at this time. And so she and I were riding circles in my driveway. She didn't want to let go. I kept getting scared and stopped pedaling. We crashed multiple times. She cried. I cried. Pretty sure she swore a few times. Made me cry more. It was a disaster. Gave up. My dad comes home. And I reiterate that I want to learn how to ride a big girl bike. And he takes me outside with the training wheels off, and there's a hill near our house, and he takes me to the top of the hill. And he says, okay, Caitlin, you're going to ride the bike. And he says, whatever you do, don't stop pedaling. And I said, you're going to hold the bike though, right? And he's like, yes, I'm going to hold the bike. And so we go. And he starts running and he's holding the back of the bicycle seat and we're running and we're going and I'm pedaling and we're going and we're going faster and faster. And it's working. And I turn to say, look, I'm doing it. And he's not there. And he's behind me and he just yells, you're doing it, just keep pedaling. And I could ride bikes. When I was a 5th year resident on April 10th in 2023, Louisville had a mass shooting. A gunman came into a bank downtown and opened fire, killed several people, and we had several victims that came to the hospital. I was on call that day. We ended up having, I think we had 10 people come to the hospital. We had 4 or 5 ORs going. It was obviously, unfortunately in America today, mass shootings are a very common occurrence. This made national headlines. I'm sure none of you remember that because there have been hundreds of mass shootings since this happened 2 years ago. This was, Kentucky is very similar to Omaha in that there are two major cities. We have Lexington and Louisville. You have Lincoln and Omaha. So this would be very similar to if a shooting happened in Omaha, that this would be grip the state with just horror. And much was the same in Kentucky. This is Andy Bashir, the governor, with our CMO, Jason Smith, who's also one of our trauma surgeons. We had several people die that day, but one of the victims who came in was a police officer. It was a young man, Officer Wilkins, who was fresh out of the police academy, who had one of the first responders to the bank shooting while the shooter was active. And the way that the bank is set up is you come in on the ground floor and there's steps that come up to the lobby. He unfortunately had not put on his gear and did not have a helmet on. And when he crested the steps, he took an isolated GSW to the head. He came in, he went to the OR with neurosurgery and ended up needing a craniectomy and got admitted to the ICU. We got called a few days later for VV ECMO. He was in severe ARDS, he'd been prone, he'd been paralyzed. And so I had called our perfusionist and the CVICU nurses he was at our trauma hospital 3 blocks away as our heart hospital to get them over here. And I go up to the 9th floor, which is where the trauma ICU, one of the trauma ICUs are, where he was, to get consent from the family. And I walk into the unit and it is full. The CMO of the hospital is there, the CNO, the entire neurosurgery department, like suits that I don't even know who are there. It was wall-to-wall individuals. I talk to the family, I get consent. My attending comes in, Victor Van Berkel, who is one of the largest individuals. He's 6'8", giant glasses, very interesting person. And so we get set up, the perfusionist comes and we go to put him on ECMO. Get him prepped, cannulate him for VV ECMO, get him on the circuit, and he codes. We do a couple of rounds of ACLS, we get him back. In the process, his trach has been dislodged, can't get it back in, scope him from above, re-intubate him, replace the trach. He's super hypotensive. Get him started on some pressors, change up some inotropes. He needs more access, put in a central line. He codes again. Few rounds of ACLS, comes back. Get a chest x-ray. Bilateral pneumothoraces. Put in 2 chest tubes. He's looking a little bit better. His A-line craps out. Put in a new A-line. I'm drenched at this point. Absolutely, completely sweated through my scrubs. And I look at Jordan, the CVICU nurse, and I was like, all right, I think we've done every single critical care procedure aside from putting a balloon pump in this guy. And I was like, how are you on your drips? Are we all right? And he was like, I haven't had to change anything. I think we're good. And we were on jet fuel at this point. And I turned to go to Van Berkel and say, all right, we just need to go. Like, I think we need to just call the ambulance and get him over to Jewish, which is the heart hospital. When I turn, and he's not hard to miss. He's huge. And I turn and he's not there. And I look out of, we have these big sliding glass doors, and I look out and he's dragged a chair to the nurse's station and he's sitting there and he's scrolling on his phone. And I look at him and I'm like, and he looks up at me and he goes, thumbs up. And with all of these people here, and I was like, all right. And so this is just sort of an ECMO circuit. And the point being is that at some point, we all end up with a piece of paper that says you graduated. You get a board certification that says you're legally allowed to practice as a surgeon. But you're never going to feel ready. There's all sorts of new environments you're going to put yourself in. You're going to be the chief on call for trauma. You're going to be the fellow. You're going to be a new attending. You're never going to feel ready. But someday you're just going to look up and you're going to be doing it because you're never going to feel ready. You're always going to be a little bit scared, but you will be able to keep, as long as you just keep huddling, you just keep doing it. You're going to look up one day and you're going to be doing it. I know it's positive. Dr. Wilkins did very well. He was in the hospital for 3 months and he did go home. But it is the experiences we have, it is the vulnerabilities that we are willing to express, and the stories that we share with ourselves, with our colleagues, with our students that make us teachers, that make us surgeons. And it is a journey, it is a process. Training is the definition of the days are long and the years are short. Thank you very much. Happy to take any questions. I went real close to going over, sorry.
Thank you so much, Dr. Griffin. Wow, what an inspiration, ground round. Thank you so much for all the time that you put into it. I can tell you put a lot of effort. Questions, comments? We have probably a minute or two for questions or comments before we start interviews, including folks from Zoom as well. Dr. Ewing.
I would just say, like, kudos to you for sharing personal experiences. I think in my residency, none of my attendings ever admitted that they were anything but perfect, even in training. And I think we all try to encourage the residents with our own stories, even though it's uncomfortable to bring back stories that were maybe we didn't do so great. But I think it's a great way to teach and like show them that we're human and that they're going to do okay even when they have a complication, and that, you know, you still have to be brave and do it because, you know, it's our job and we're fighting.
No, I agree. I
Thank
think
you.
when there's this false sense of security that when you make it to, oh, like I'm a chief, I'm a fellow, I'm an attending, that you like, oh, I've escaped having to admit that I have I've made any mistakes, and like nobody's gonna find out about like the dirty little secrets that I like screwed up as an intern or as a junior in training. And I think like owning that it's super important because it normalizes it, and it's hard, but I think it's so necessary.
Okay, thanks for the nice presentation. So obviously we are going to go through these hardships of mistakes, learning and everything. But so what's your lesson from all these things, and how do you, so what your recommendations are to the residents and to the students, how to pull yourself out from the lows after going through these hard cases or the learning from the mistakes?
So I think cultivating a community, that was huge for me. I think when you're deciding, one of the really big deciding factors for me in choosing a place to train and in the choices I made during training was I have a very strong community and a family really that I built in training. I can promise you my phone right now probably has 3 or 4 texts from that family of residents that I have, that it's having people, unless your spouse or your parents are surgeons, it's having those people who understand when you have like when you crush a case and you've like, my friends understand when I was starting out in fellowship, I was really stressed about lobes, stressed me out so much. And I was like, I'm never gonna be able to do a lobe. And when I did my first lobe here and I texted them that I was like, I did my first lobe on an 87-year-old who just had a 5-vessel cabbage, like they understood that was huge. And when I had a patient who had an air leak after a bad decort, you know, my friend Dylan, who's a colorectal surgeon, is like, Caitlin, you didn't give him pneumonia. Like they understand that. And that's, I think, having people that you can have those conversations with and be vulnerable with, because they were there when you dropped the lung, when you put your first subclavian line in. And which I'm not pointing that out to him. I told him that I dropped the hell out of the lung on the first subclavian that I put in, is valuable.
We have time for one more question or comments. Dr. Koval.
I really liked your comments about like the normal Tuesday, you're talking to somebody about their esophageal cancer or, you know, something, and it's like the worst day of that person's life. One of the best lessons I got, it might come as a shock because I have such an abrasive personality, but the only patient complaint that I know of that was filed against me was when I was an intern. It was overnight, a nurse paging me when I was like doing a million things about changing the wording on a consent because it didn't say the correct thing to give blood. And I was like in the patient's room talking to the nurse, like, well, this doesn't make any sense. Why are we doing this? And so the patient complained that we didn't know what we were doing. And then the lesson I got was pay attention to the way you present yourself. So when attending's having a conversation about somebody's path came back and you're like giving them news that they have cancer and it's the worst day of their life. If you're like in the back on your phone or not paying attention or talking to the nurse, as from a patient's perspective, people really notice that. So.
I
Want
have-
to close?
Oh, sorry, I haven't been here super long, but if you guys round with me, if I have a conversation, if I'm consenting someone for something, if I'm having any kind of a conversation with patients on rounds, I will literally go to another room and drag a chair into the room and sit at the patient's bedside. There's data that shows that if you are sat in the room with a patient, like physically sitting, and I will not sit on the bed because one, that's creepy, and two, that's gross because we had bed bugs at one point and I just like never looked back. But that their perception of the time you spend with them is longer than if you actually physically spent longer time, but you were stood in the room. And so, but yes, so it's like, it's the presence, it's the perception. So I almost always take a seat in the room when I'm having those conversations with patients, even inpatient.
I'll close with two comments. What resonated the most with the hallways have eyes remind me of what my late father used to say, son, if we're not watching you, God is watching you. And then we had our ground rounds. Dr. Ranga actually said, professionalism is what you say and do when your boss is not watching you. So that resonated with me. And then I went back to my phone when we were getting references from one of our colleagues, and he said, Dr. Griffin is going to work very hard. She's going to take excellent care of patients. She loves to teach, and she'll never disappoint. So thanks for everything that you do. We appreciate it, Dr. Griffin. Wonderful ground rounds. Let's give Dr. Griffin a round of applause.